Welcome to this video entitled, Overview of CNS, Bone and Joint Infections. Lecture Objectives. In this lecture, we will explore some of the most important infections affecting the central nervous system, spine, and joints. Understanding these conditions can make the difference between rapid recovery and devastating complications. First, we will understand how the causes of bacterial meningitis change with age. The bacteria responsible for meningitis in newborns are very different from those seen in older children, adults, and the elderly. Recognizing these age-dependent pathogens helps clinicians choose the right antibiotics quickly, often before laboratory results are available. In meningitis, every minute counts. Next, we will learn to differentiate between viral meningitis and encephalitis. Although both can present with fever and neurological symptoms, they affect the body differently. Viral meningitis primarily involves inflammation of the protective membranes surrounding the brain and spinal cord. Encephalitis, on the other hand, involves inflammation of the brain tissue itself. Patients with encephalitis are more likely to develop altered mental status, behavioral changes, seizures, and focal neurological deficits. Identifying the difference guides both diagnosis and treatment. We will also recognize the clinical stages and urgency of spinal epidural abscess. This condition often begins subtly, with back pain and fever. As the infection progresses, nerve root irritation, muscle weakness, sensory loss, and eventually paralysis can occur. Early recognition is essential because delayed treatment may result in permanent neurological damage. Spinal epidural abscess should always be considered a medical emergency. Another major focus will be osteomyelitis, an infection of bone that can occur through bloodstream spread, direct inoculation, or extension from nearby tissues. We will master its classification and understand the diagnostic gold standards used to confirm the disease. Imaging studies provide valuable clues, but bone biopsy with microbiological analysis often offers the most definitive diagnosis and guides targeted therapy. Finally, we will evaluate the presentation and management of septic arthritis and prosthetic joint infections. Septic arthritis typically presents with a painful, swollen, and immobile joint requiring urgent intervention to prevent irreversible cartilage destruction. Prosthetic joint infections present unique diagnostic and therapeutic challenges, often requiring prolonged antimicrobial therapy and, in some cases, surgical management. By the end of this lecture, you will be better equipped to recognize these serious infections early, interpret their clinical features confidently, choose appropriate diagnostic strategies, and appreciate the urgency required to improve patient outcomes. These are conditions where timely action truly saves function, and sometimes saves lives. Section 1 introduces us to central nervous system infections, a group of conditions where early recognition can save both brain function and life. These infections may affect the protective coverings of the brain and spinal cord, the brain tissue itself, or form dangerous collections of pus within the skull. We begin with meningitis, which is inflammation of the meninges, the thin membranes surrounding the brain and spinal cord. Patients often present with fever, severe headache, neck stiffness, nausea, vomiting, and sensitivity to light. But not all meningitis is the same. The underlying cause determines both the severity and the treatment approach. Bacterial meningitis is one of the most feared neurological emergencies. It develops rapidly and can progress within hours. Patients may become confused, lethargic, or develop seizures. Immediate diagnosis and prompt antibiotic therapy are critical because delays can lead to hearing loss, neurological disability, or death. Viral meningitis is generally less severe and often resolves with supportive care. Patients may still experience intense headaches, fever, and neck stiffness, but they usually maintain normal mental status. Although the symptoms may overlap with bacterial disease, the prognosis is often much better. Fungal meningitis tends to occur in individuals with weakened immune systems. The symptoms can develop gradually over days to weeks. Persistent headaches, fever, and subtle neurological changes should raise suspicion. Early recognition is essential because diagnosis is often delayed. Tuberculous meningitis is another important cause, especially in regions where tuberculosis remains common. Unlike acute bacterial meningitis, it usually has an insidious onset. Patients may complain of prolonged fever, weight loss, headaches, and progressive confusion. Without treatment, devastating neurological complications can occur. Beyond meningitis, we also encounter suppurative infections, where pus accumulates within confined spaces of the central nervous system. These collections can exert pressure on delicate brain structures and rapidly become life-threatening. A brain abscess is a localized pocket of infection within the brain tissue itself. It may arise from bloodstream spread, nearby infections such as sinusitis or otitis media, or direct trauma. Patients may present with headache, fever, focal neurological deficits, or seizures. Because symptoms can be subtle at first, maintaining a high index of suspicion is crucial. Subdural empyema refers to pus collecting between the dura and arachnoid membranes. This condition often progresses quickly and requires urgent intervention. Patients may deteriorate rapidly with worsening headache, fever, altered consciousness, and focal deficits. The key message throughout this section is simple but powerful. CNS infections are true medical emergencies. Recognizing the warning signs early, understanding their different presentations, and initiating timely treatment can dramatically improve outcomes. In these conditions, fast thinking and decisive action save lives. Bacterial meningitis is a true medical and neurological emergency. It can progress with alarming speed, turning a healthy person critically ill within just a few hours. That is why clinicians often begin treatment before all diagnostic results are available. In bacterial meningitis, time is brain, and sometimes, time is life. One of the most important concepts to remember is that the bacteria causing meningitis vary with age and immune status. Knowing the likely pathogens helps clinicians choose the most effective empirical antibiotics right from the start. In neonates, the usual culprits are bacteria acquired around the time of birth. Group B Streptococcus remains one of the leading causes of neonatal meningitis. It can be transmitted from the mother's genital tract during delivery. Escherichia coli is another important pathogen, particularly strains possessing virulence factors that allow them to invade the central nervous system. Listeria monocytogenes also deserves special attention in this age group because newborn immune systems are still developing and may struggle to control this intracellular organism. As children transition into adulthood, the pattern changes. In adults, Streptococcus pneumoniae becomes the most common cause of community-acquired bacterial meningitis. This organism can invade the bloodstream from sites such as the respiratory tract and spread to the meninges. Pneumococcal meningitis is often severe and carries a significant risk of neurological complications if treatment is delayed. Another important adult pathogen is Neisseria meningitidis. This bacterium is particularly known for causing outbreaks in crowded settings such as schools, dormitories, military barracks, and refugee camps. Patients may develop the classic petechial or purpuric rash, a warning sign that should immediately raise suspicion for meningococcal disease. Rapid progression to septic shock can occur, making urgent intervention essential. Older adults and immunocompromised individuals present a unique challenge. In these populations, Listeria monocytogenes re-emerges as a major pathogen. Conditions that weaken cell-mediated immunity increase susceptibility to this infection. An important clinical pearl is that Listeria is inherently resistant to cephalosporins, antibiotics commonly used in empirical meningitis regimens. This means additional antimicrobial coverage is required whenever Listeria risk factors are present. The key takeaway is simple. Age matters. Immune status matters. The likely pathogen changes across the lifespan, and understanding these epidemiological patterns allows clinicians to act quickly and appropriately. Early recognition, prompt antibiotic selection, and immediate supportive care remain the cornerstones of improving outcomes in bacterial meningitis. In this disease, hesitation can have devastating consequences, but informed action can save lives. Bacterial meningitis often presents dramatically, but the symptoms are not always textbook. One of the biggest clinical lessons is this: never rule out meningitis simply because a patient does not have every classic sign. Most people learn about the classic triad of bacterial meningitis: fever, neck stiffness, and altered mental status. These features are strongly associated with the disease. However, the complete triad is present in fewer than half of all patients. In other words, more than half of patients may not fit the classic picture. That is why clinicians must maintain a high level of suspicion. Fever is often the first clue. Patients may report chills, feeling unusually hot, or simply feeling very unwell. The body's immune response is reacting aggressively to the infection invading the meninges. Neck stiffness, also called nuchal rigidity, occurs because inflammation irritates the meninges surrounding the spinal cord. Patients often describe difficulty bending the neck forward. Even simple movements can become painful and restricted. Altered mental status can range from subtle confusion and irritability to profound lethargy, disorientation, and coma. Family members may notice that the patient is acting differently, responding slowly, or becoming increasingly difficult to awaken. Changes in mental status should always raise concern for central nervous system involvement. During physical examination, clinicians may look for meningeal signs. One of these is nuchal rigidity, where passive neck flexion becomes difficult because of stiffness and pain. Another classic finding is Koenig's sign. With the patient's hip flexed, attempts to straighten the knee produce pain and resistance. This occurs because stretching the inflamed meninges triggers discomfort. Brudzinski's sign is another helpful clue. When the examiner gently flexes the patient's neck, the hips and knees may involuntarily bend in response. Although these signs can support the diagnosis, their absence does not exclude meningitis. Patients frequently experience other symptoms as well. Headache is one of the most common complaints and is often described as severe and diffuse. Photophobia, or sensitivity to light, may make even normal room lighting unbearable. Nausea and vomiting can occur because of increased intracranial irritation and pressure. Some patients may also develop seizures, which indicate significant cortical involvement and often signal more severe disease. The most important message is this: bacterial meningitis can be unpredictable. A patient may have only a few symptoms at presentation. Early recognition depends on putting the pieces together rather than waiting for the complete classic picture to appear. When fever, headache, neck stiffness, confusion, or seizures occur together, clinicians must think fast. Prompt evaluation and treatment can mean the difference between full recovery and life-altering complications. In meningitis, suspicion saves lives. Diagnosing bacterial meningitis is a race against time. Clinicians must move quickly because delaying treatment can lead to permanent neurological damage or even death. The challenge is finding the balance between obtaining an accurate diagnosis and starting life-saving therapy without unnecessary delays. The gold standard for diagnosing bacterial meningitis is the lumbar puncture, often called an LP or spinal tap. This procedure allows clinicians to collect cerebrospinal fluid, or CSF, the fluid that bathes and protects the brain and spinal cord. Examining this fluid provides some of the most important clues to the diagnosis. In bacterial meningitis, the CSF usually has a very characteristic pattern. One of the hallmark findings is neutrophilic pleocytosis. In simple terms, this means there is a large increase in neutrophils, the white blood cells that rush to fight bacterial infections. Protein levels in the CSF are typically elevated. This happens because inflammation disrupts the normal blood-brain barrier, allowing proteins to leak into the cerebrospinal fluid. Glucose levels are often low. Bacteria consume glucose, and inflammatory cells also use it rapidly. As a result, the amount of sugar in the CSF decreases compared with normal levels. Another important measurement is the opening pressure recorded during the lumbar puncture. Patients with bacterial meningitis frequently have elevated opening pressures, reflecting increased intracranial pressure caused by inflammation and impaired CSF circulation. However, not every patient should undergo an immediate lumbar puncture. In certain situations, clinicians should obtain a computed tomography, or CT scan, before performing the procedure. The reason is safety. If significant brain swelling or a mass effect is present, removing CSF could increase the risk of brain herniation, a catastrophic complication. Several red flags should prompt a CT scan before lumbar puncture. One is papilledema, which refers to swelling of the optic disc seen during fundoscopic examination and may indicate raised intracranial pressure. Another is the presence of focal neurological deficits, such as weakness affecting one side of the body or abnormalities in speech and vision. New-onset seizures are also considered an important warning sign. In addition, patients with severe immunosuppression may be at higher risk of intracranial lesions and should be evaluated carefully before proceeding with lumbar puncture. Modern molecular techniques have further improved diagnosis. Polymerase chain reaction, or PCR-based assays, can rapidly identify bacterial pathogens directly from cerebrospinal fluid. These tests are especially valuable when antibiotics have already been started, reducing the likelihood of positive cultures. The key message is simple: think fast, diagnose carefully, and never delay treatment unnecessarily. Lumbar puncture remains the cornerstone of diagnosis, while imaging and molecular tools help clinicians make safer and more accurate decisions. In bacterial meningitis, every hour matters, and prompt action saves lives. Bacterial meningitis is one of the few medical conditions where treatment should begin the moment you strongly suspect the diagnosis. Waiting for every test result can cost precious time. In this disease, delays are dangerous, and early intervention saves lives. The first priority is immediate empiric antibiotic therapy. Empiric means starting broad-spectrum antibiotics based on the most likely organisms before the exact pathogen is identified. The choice of antibiotics is guided by factors such as the patient's age, immune status, and underlying risk factors. A crucial principle to remember is this: Do not delay antibiotics while waiting for imaging studies or a lumbar puncture. If bacterial meningitis is suspected, blood cultures should be obtained promptly if possible, but antimicrobial treatment must begin without unnecessary hesitation. Every hour of delay has been associated with worse outcomes. Once laboratory results and culture data become available, therapy can be narrowed to specifically target the identified organism. This approach provides immediate protection while allowing more precise treatment later. Another important component of management is adjunctive dexamethasone therapy. When bacteria are destroyed by antibiotics, they release inflammatory substances that can intensify the body's immune response within the central nervous system. Ironically, this inflammation can contribute to neurological injury. Dexamethasone, a corticosteroid, helps reduce this excessive inflammatory response. It has been shown to decrease the risk of neurological complications, including hearing loss and other long-term sequelae in selected patients. Timing is everything. Dexamethasone should be administered before, or at the same time as, the first dose of antibiotics. Giving it later significantly reduces its benefit. Management, however, extends beyond antibiotics and steroids. Supportive care plays a vital role in patient survival and recovery. Many patients require close monitoring in a high-dependency unit or intensive care setting. Clinicians must pay careful attention to intracranial pressure, or ICP. Inflammation and impaired cerebrospinal fluid circulation can increase pressure within the skull, potentially leading to neurological deterioration. Measures to control elevated intracranial pressure may be necessary depending on the clinical situation. Hemodynamic stability is equally important. Patients may develop hypotension, septic shock, or organ dysfunction as the infection progresses. Maintaining adequate blood pressure and ensuring proper oxygen delivery to the brain and other organs are essential goals of care. Intravenous fluids, vasopressors, and supportive interventions may be required. Seizures, electrolyte disturbances, and respiratory compromise should also be identified and managed promptly. Recovery depends not only on eliminating the infection, but also on preventing secondary complications. The key message is clear. Act early. Start empiric antibiotics immediately. Use dexamethasone at the right time. Provide meticulous supportive care. Successful treatment of bacterial meningitis requires urgency, teamwork, and constant vigilance. In this neurological emergency, rapid decisions can preserve hearing, protect brain function, and save lives. Viral infections of the central nervous system can present in two very different ways: viral meningitis and viral encephalitis. Although the terms are sometimes used interchangeably, they involve different structures of the nervous system and often have very different clinical implications. Viral meningitis occurs when viruses inflame the meninges, the protective membranes surrounding the brain and spinal cord. Fortunately, it usually follows a relatively benign course. Most patients recover completely with supportive care, although the symptoms can still be quite distressing. Patients with viral meningitis commonly complain of headache, fever, and neck stiffness. They may also experience nausea, vomiting, and sensitivity to light. Despite these symptoms, one important feature often remains intact: mental status. Patients are generally alert, oriented, and able to interact normally. This preserved level of consciousness is a valuable clinical clue. Among the most common causes of viral meningitis are enteroviruses. These include Coxsackie viruses and echoviruses, which account for a large proportion of cases worldwide. These viruses spread easily, particularly during the warmer months, and frequently affect children and young adults. While the illness can be uncomfortable, reassurance and supportive management are often sufficient. Viral encephalitis, however, is a very different story. Encephalitis refers to inflammation involving the brain parenchyma itself. When the brain tissue becomes inflamed, neurological function can rapidly deteriorate. This condition demands urgent recognition and management because it carries a much higher risk of serious complications. One of the hallmark features of encephalitis is altered consciousness. Patients may become confused, unusually drowsy, disoriented, or agitated. Family members are often the first to notice that the person is not acting like themselves. Seizures may also occur as irritated brain tissue becomes electrically unstable. In some cases, seizures may be the presenting symptom. Focal neurological deficits can develop as well, depending on the area of the brain involved. Patients may experience weakness affecting one side of the body, speech difficulties, abnormal movements, personality changes, or memory impairment. A simple way to distinguish these two conditions is to remember this principle. Meningitis affects the coverings of the brain, while encephalitis affects the brain itself. If a patient has fever, headache, and neck stiffness but remains mentally clear, viral meningitis becomes more likely. However, when those symptoms are accompanied by confusion, behavioral changes, seizures, or focal deficits, clinicians must strongly suspect encephalitis and act quickly. The key takeaway is that not all viral CNS infections are created equal. Viral meningitis is often self-limiting and reassuring in prognosis. Viral encephalitis, on the other hand, is potentially life-threatening and requires prompt evaluation and treatment. Recognizing the difference early can dramatically influence outcomes and help protect the most important organ in the body, the brain. When discussing viral encephalitis, two viruses deserve special attention because recognizing them early can save lives: herpes simplex virus type 1, or HSV1, and varicella zoster virus, better known as VZV. HSV1 is the leading cause of sporadic fatal encephalitis worldwide. Unlike many viral infections that resolve on their own, HSV encephalitis is a neurological emergency. Without prompt treatment, mortality rates are extremely high, and survivors may be left with significant cognitive and neurological deficits. One reason HSV1 is so distinctive is its tendency to affect the temporal lobes of the brain. These regions play critical roles in language, memory, emotions, and behavior. As a result, patients often present with unusual symptoms that may initially be mistaken for psychiatric illness. Family members may notice sudden personality changes. A previously calm individual may become agitated, confused, or inappropriate. Others may develop memory problems or struggle to find the right words during conversation. This language disturbance, known as aphasia, is a classic clue to temporal lobe involvement. Headache and fever are also common. As the disease progresses, altered consciousness may develop. Patients can become increasingly drowsy, disoriented, or difficult to awaken. Seizures frequently occur and may even be the first sign that something serious is happening within the brain. The most important clinical message is simple. If HSV encephalitis is suspected, treatment must begin immediately. Urgent intravenous acyclovir is the cornerstone of management. Clinicians should not wait for polymerase chain reaction, or PCR, results before starting therapy. Every hour of delay allows ongoing viral replication and increases the risk of irreversible brain injury. Early acyclovir administration dramatically improves outcomes and has transformed what was once an almost uniformly fatal disease. Another important viral pathogen is varicella zoster virus. Most people recognize VZV as the virus responsible for chickenpox and shingles. However, its neurological effects extend far beyond a skin rash. VZV can invade the central nervous system and cause encephalitis, meningitis, and cerebral vasculitis. Vasculitis refers to inflammation of blood vessels supplying the brain. This inflammation can reduce blood flow and increase the risk of stroke-like events. A particularly important point is that VZV-related CNS disease can occur with or without the characteristic shingles rash. The absence of skin lesions should never exclude the diagnosis. Clinicians must maintain a high index of suspicion, especially in older adults and immunocompromised patients presenting with unexplained neurological symptoms. The key takeaway is clear. Fever, confusion, seizures, behavioral changes, or new language difficulties should immediately raise concern for viral encephalitis. Think about HSV-1. Think about VZV. Start treatment promptly. In these infections, acting early can preserve memory, protect brain function, and save lives. Tuberculous meningitis is one of the most serious forms of chronic meningitis. Unlike bacterial meningitis, which often develops within hours, tuberculous meningitis usually progresses slowly over days to weeks. This gradual onset can make it difficult to recognize early, allowing significant neurological damage to occur before the diagnosis is made. The disease begins with infection by Mycobacterium tuberculosis. Small tuberculous lesions, known as rich foci, may develop within the brain or its surrounding tissues during the initial spread of tuberculosis through the bloodstream. These tiny foci can remain silent for some time. Trouble begins when one of these lesions ruptures into the subarachnoid space, releasing bacteria and triggering a powerful inflammatory response within the meninges. One of the hallmark features of tuberculous meningitis is basal meningitis. Thick, gelatinous inflammatory exudates accumulate around the base of the brain. This sticky material can wrap around cranial nerves and important blood vessels, leading to multiple neurological complications. Hydrocephalus is a common consequence. The inflammatory exudate interferes with the normal circulation and absorption of cerebrospinal fluid. As fluid builds up within the ventricles, intracranial pressure rises. Patients may develop worsening headaches, vomiting, drowsiness, and progressive decline in consciousness. Another devastating complication is vasculitis. The inflamed exudate can involve cerebral blood vessels, causing narrowing and reduced blood flow to the brain. This increases the risk of ischemic strokes, even in relatively young patients. New weakness, speech difficulties, facial drooping, or focal neurological deficits should raise concern for vascular involvement. Clinically, tuberculous meningitis often evolves through recognizable stages. In stage 1, patients remain alert and conscious. They may complain of persistent headache, low-grade fever, malaise, and subtle personality changes. Because the symptoms are nonspecific, diagnosis is frequently delayed. In stage 2, neurological signs become more apparent. Confusion, lethargy, cranial nerve palsies, and focal deficits may emerge as inflammation progresses. Stage 3 represents advanced disease. Patients may become stuporous or comatose. Severe neurological deficits, seizures, and signs of raised intracranial pressure are common. Outcomes worsen significantly once patients reach this stage. Management requires prompt initiation of anti-tuberculosis therapy using a multi-drug regimen to eradicate the infection. However, treating the bacteria alone is not enough. Adjunctive corticosteroids are considered mandatory because they reduce excessive inflammation, decrease cerebral edema, and improve survival while lowering the risk of long-term neurological complications. The key message is simple. Think of tuberculous meningitis in any patient with prolonged fever, persistent headache, and gradually worsening neurological symptoms. Early recognition and treatment are critical. The sooner therapy begins, the greater the chance of preserving brain function and preventing permanent disability. In tuberculous meningitis, delayed diagnosis can be devastating, but timely intervention can truly change lives. Cryptococcal meningitis is one of the most important causes of chronic fungal meningitis, particularly in individuals with weakened immune systems. Unlike acute bacterial meningitis, this infection often develops gradually. Symptoms may creep in over days or even weeks, making it easy to overlook in the early stages. The disease is caused by Cryptococcus, an encapsulated yeast that can spread from the lungs through the bloodstream and eventually invade the central nervous system. Once it reaches the meninges, it can trigger a potentially life-threatening infection that requires prompt recognition and specialized treatment. Certain groups are especially vulnerable. Patients with advanced HIV infection are at the highest risk, particularly when CD4 counts fall below 100 cells per microliter. At these low CD4 levels, the immune system struggles to control opportunistic infections. Cryptococcal meningitis remains a major cause of morbidity and mortality in this population. Transplant recipients are another high-risk group. The immunosuppressive medications used to prevent organ rejection can also reduce the body's ability to fight fungal pathogens. Any immunocompromised patient presenting with persistent headache and constitutional symptoms should prompt consideration of cryptococcal disease. One of the defining features of cryptococcal meningitis is markedly elevated intracranial pressure, or ICP. This is more than just a laboratory finding. It has major clinical consequences and often contributes significantly to patient symptoms and outcomes. Patients commonly report persistent headaches that gradually worsen over time. They may also experience nausea, vomiting, blurred vision, double vision, or increasing drowsiness. Some develop cranial nerve palsies or altered mental status as intracranial pressure rises. In severe cases, uncontrolled intracranial pressure can become life-threatening. Diagnosing cryptococcal meningitis has become more efficient with the use of cryptococcal antigen testing, commonly known as CRAG testing. This test is highly sensitive and can detect cryptococcal polysaccharide antigen in cerebrospinal fluid or blood. Its accuracy and rapid turnaround have made it an invaluable diagnostic tool, especially in resource-limited settings where early diagnosis is critical. Management follows a staged approach. The first phase, known as induction therapy, focuses on rapidly reducing the fungal burden using potent antifungal medications. This is followed by consolidation therapy to eliminate residual infection and then maintenance therapy to prevent relapse, particularly in patients with ongoing immunosuppression. Equally important is the management of elevated intracranial pressure. Treating the fungus alone is not enough. Serial lumbar punctures are often required to drain cerebrospinal fluid and relieve pressure. These repeated procedures can dramatically improve symptoms and reduce the risk of neurological complications. The key takeaway is simple. Think about cryptococcal meningitis in immunocompromised patients with persistent headaches and progressive neurological symptoms. Recognize the danger of elevated intracranial pressure. Use cryptococcal antigen testing early. Treat in stages, and never underestimate the importance of serial lumbar punctures. In cryptococcal meningitis, Controlling both the infection and the pressure can save lives and preserve neurological function. A brain abscess is a localized collection of pus within the brain tissue. Although relatively uncommon, it represents a true neurological emergency because the growing abscess behaves like a space-occupying lesion. As pressure builds inside the rigid skull, even a small delay in diagnosis can have devastating consequences. Brain abscesses usually develop when microorganisms gain access to the brain through predictable routes. One common pathway is contiguous spread from nearby infections. Chronic sinusitis can extend into adjacent brain structures, particularly the frontal lobes. Similarly, middle ear infections and mastoiditis can spread directly to the temporal lobe or cerebellum. What may begin as a seemingly routine ear or sinus infection can, in rare circumstances, evolve into a life-threatening intracranial complication. Another important route is hematogenous spread. In this situation, bacteria travel through the bloodstream from distant sites of infection. Infective endocarditis is a classic example. Vegetations on infected heart valves can release septic emboli that lodge within cerebral blood vessels and seed the brain, eventually forming abscesses. Patients with congenital heart disease and right-to-left cardiac shunts are also at increased risk because circulating pathogens can bypass normal pulmonary filtration. The clinical presentation often reflects the fact that a brain abscess acts as a mass lesion. Headache is the most common symptom and is frequently the earliest complaint. It may be persistent, progressive, and resistant to simple analgesics. As the abscess enlarges, focal neurological deficits may emerge. Depending on the location, patients may develop weakness on one side of the body, speech difficulties, visual disturbances, sensory changes, or coordination problems. Seizures can occur when the surrounding brain tissue becomes irritated. Some patients also experience fever, although its absence does not exclude the diagnosis. One critical principle must always be remembered. Do not perform a lumbar puncture when a brain abscess is suspected. Because the lesion increases intracranial pressure and creates mass effect, removing cerebrospinal fluid can precipitate brain herniation, a catastrophic and often fatal complication. Neuroimaging, particularly contrast-enhanced CT or MRI, should be obtained instead to establish the diagnosis safely. Management requires a combination of medical and surgical approaches. Broad-spectrum intravenous antibiotics should be started promptly to target the likely pathogens while microbiological data are being obtained. Treatment is later adjusted according to culture results and clinical response. However, antibiotics alone are not always sufficient. Many patients require surgical aspiration or drainage of the abscess. This procedure reduces intracranial pressure, relieves mass effect, and provides material for microbiological analysis to guide targeted therapy. The key message is simple. Think of brain abscess in patients with persistent headache, focal neurological signs, seizures, and a history of nearby or bloodstream infections. Avoid lumbar puncture. Use imaging early. Combine antibiotics with timely neurosurgical intervention. In brain abscesses, rapid recognition and decisive management can save both brain function and life. A spinal epidural abscess is a collection of pus that forms in the space between the spinal dura and the vertebral column. Although it is relatively uncommon, it is one of the most time-sensitive infections in medicine. Failure to recognize it early can lead to irreversible neurological damage and permanent paralysis. The condition often begins quietly. Patients may initially complain of nothing more than severe back pain. Because back pain is so common, the diagnosis can easily be missed. However, When back pain is accompanied by fever, neurological symptoms, or risk factors for infection, clinicians must think about a spinal epidural abscess. Certain groups are particularly vulnerable. People living with diabetes mellitus are at increased risk because high blood glucose levels can impair immune function and make infections more difficult to control. Injection drug users also face a higher risk. Repeated bloodstream exposure to bacteria can allow microorganisms to seed the epidural space and establish infection. A history of spinal surgery, epidural procedures, or instrumentation should raise suspicion as well. Any disruption of normal spinal anatomy can create an opportunity for bacteria to invade deeper tissues. The dominant pathogen responsible for spinal epidural abscess is Staphylococcus aureus. This organism accounts for the majority of cases and should always be considered when selecting initial antibiotic therapy. Both methicillin-sensitive and methicillin-resistant strains may be involved. One of the most important aspects of this condition is understanding its clinical progression. The disease often follows a predictable sequence of stages. The first stage is localized back pain. Patients may describe deep, persistent pain that gradually worsens over time. The discomfort is often severe and may not improve with routine pain medications. As the abscess enlarges, nerve roots become irritated. This leads to radicular pain, characterized by sharp, shooting pain radiating along the distribution of affected nerves. Patients may also experience tingling or abnormal sensations. The next stage involves spinal cord compression. Weakness begins to appear. Patients may struggle to walk, climb stairs, or maintain balance. Sphincter dysfunction can develop, leading to urinary retention, incontinence, or bowel disturbances. These symptoms represent major warning signs that demand immediate action. Without urgent intervention, paralysis may occur. Once complete paralysis develops, neurological recovery becomes far less likely. This is why early recognition is absolutely critical. Management of spinal epidural abscess is a true neurosurgical emergency. Prompt diagnosis, usually with magnetic resonance imaging, allows clinicians to identify the extent of infection and spinal cord compression. Urgent surgical decompression is often required to remove the abscess and relieve pressure on the spinal cord. Intravenous antibiotics are administered simultaneously to eradicate the underlying infection. The key message is simple. Severe back pain should never be dismissed when accompanied by risk factors or neurological symptoms. Think about spinal epidural abscess. Recognize the stages. Act before weakness progresses to paralysis. In this condition, early diagnosis and urgent decompression can mean the difference between walking and lifelong disability. Welcome to Section 2, where we shift our focus from infections of the brain and spinal cord to infections of the bone. Osteomyelitis may sound straightforward, but diagnosing and treating it can be surprisingly complex. These infections often develop quietly, mimic other conditions, and require a thoughtful, multidisciplinary approach. Osteomyelitis simply means infection of the bone. However, not all cases are the same. Understanding how these infections are classified helps clinicians predict the likely pathogens, choose the right investigations, and develop effective treatment plans. One way to classify osteomyelitis is by the route of infection. Some infections occur through hematogenous spread, where bacteria travel through the bloodstream and seed the bone. This pattern is more common in children and may affect the long bones. Other cases result from contiguous spread. In these situations, infection extends directly from nearby tissues, such as diabetic foot ulcers, pressure injuries, or soft tissue infections. Trauma and surgical procedures can also introduce bacteria directly into bone, especially when orthopedic hardware is involved. Osteomyelitis can also be classified according to duration. Acute osteomyelitis develops over days to weeks and may present with fever, localized pain, swelling, and tenderness. Chronic osteomyelitis evolves over months and is often characterized by recurrent drainage, persistent pain, and areas of dead bone known as sequestra. Diagnosing osteomyelitis requires combining clinical suspicion with appropriate investigations. Patients often complain of deep, persistent bone pain that worsens with movement or weight bearing. Redness, warmth, and swelling may be present, although these signs can be subtle. Laboratory studies such as inflammatory markers can support the diagnosis, but they are not specific. Imaging plays a major role. Plain radiographs are usually obtained first, although early disease may not be visible. Magnetic resonance imaging is particularly valuable because it can detect bone and soft tissue involvement before significant structural damage occurs. Despite advances in imaging, the diagnostic gold standard remains bone biopsy with microbiological culture. Obtaining a tissue sample allows clinicians to identify the causative organism and tailor antimicrobial therapy accordingly. This targeted approach improves treatment success and reduces unnecessary antibiotic exposure. Management strategies depend on the severity and type of infection. Prolonged antibiotic therapy is often required because bone infections can be difficult to eradicate. Initial treatment may begin empirically and later be adjusted based on culture results. Some patients also require surgical intervention. Debridement of infected and necrotic tissue helps reduce bacterial burden and promotes healing. In chronic disease, surgery may be essential for definitive management. The key message is simple. Think of osteomyelitis in patients with persistent bone pain, especially when risk factors are present. Classify the infection carefully. Use imaging wisely. Confirm the diagnosis whenever possible with bone culture. Combine appropriate antibiotics with surgery when needed. Early recognition and targeted treatment can preserve function, prevent complications, and improve quality of life. Understanding osteomyelitis begins with one simple question. How did the infection reach the bone? The answer helps explain the disease process, predicts the organisms involved, and guides treatment decisions. Although osteomyelitis refers to infection of bone, the pathways leading to that infection can be very different. One major pathway is hematogenous spread. In this form, bacteria travel through the bloodstream and settle within the bone. This pattern is especially common in children. Because growing bones have a rich blood supply, microorganisms can easily lodge in the metaphysis of long bones such as the femur, tibia, and humerus. A child with hematogenous osteomyelitis may present with fever, localized pain, refusal to bear weight, or limping. Sometimes, the symptoms develop rapidly, prompting urgent medical evaluation. In adults, hematogenous osteomyelitis has a different pattern. Instead of affecting long bones, it more commonly involves the vertebral bodies of the spine. Patients often complain of persistent back pain that gradually worsens over time. Fever may be absent, making diagnosis more challenging. Because chronic back pain is common, vertebral osteomyelitis can easily be overlooked unless clinicians maintain a high index of suspicion. Another important mechanism is contiguous spread, which is actually the most common route of osteomyelitis in many adult populations. In this situation, infection spreads directly from nearby soft tissues into the underlying bone. Diabetic foot ulcers are classic examples. Long-standing diabetes can impair circulation and reduce protective sensation, allowing small wounds to progress unnoticed. As infection extends deeper, the underlying bone may become involved. Pressure sores can lead to a similar process. Patients who are immobilized for prolonged periods may develop skin breakdown over bony prominences. If these wounds become infected, bacteria can gradually invade adjacent bone structures. A third pathway is direct inoculation. Here, microorganisms gain immediate access to bone through disruption of normal barriers. Traumatic injuries, particularly open fractures, create an opportunity for bacteria to enter the bone at the time of injury. Orthopedic surgery can also introduce infection. Although surgical procedures are performed under sterile conditions, implanted hardware and prosthetic materials can occasionally become colonized by bacteria. Once infection becomes established around these devices, eradication can be particularly difficult. Regardless of the route, the pathogenesis follows a similar pattern. Bacteria multiply within bone tissue, triggering inflammation and increased pressure within the rigid bony environment. Blood flow may become compromised, leading to areas of ischemia and bone death. These necrotic areas can shelter bacteria from both antibiotics and immune defenses, contributing to persistent or recurrent infection. The key takeaway is simple. Ask how the bacteria got there. Think bloodstream spread in children and vertebral disease in adults. Remember that diabetic ulcers and pressure injuries commonly spread into bone. Consider trauma and surgery as direct routes of infection. Understanding the pathogenesis of osteomyelitis is the first step toward early diagnosis, effective treatment, and preventing long-term complications. When it comes to osteomyelitis, identifying the likely pathogen is one of the most important steps in choosing the right treatment. The infecting organism often depends on the patient's age, underlying conditions, and how the infection reached the bone. Knowing these classic associations can provide valuable clinical clues. The most common pathogen overall is Staphylococcus aureus. If you remember only one organism associated with osteomyelitis, make it this one. Staphylococcus aureus has a remarkable ability to adhere to bone tissue, evade immune defenses, and establish deep-seated infections. It can cause both acute and chronic disease. It affects children and adults alike. It may spread through the bloodstream, enter through trauma, or infect surgical sites. Methicillin-resistant strains, commonly known as MRSA, have also become important considerations when selecting empiric antibiotic therapy. Another classic association involves Salmonella species and sickle cell disease. Patients with sickle cell disease experience repeated episodes of vascular occlusion and tissue injury, creating an environment where certain bacteria can establish infection more easily. Although Staphylococcus aureus remains common even in these patients, Salmonella osteomyelitis is a well-known examination favorite and an important clinical association to remember. When a patient with sickle cell disease presents with fever and bone pain, Salmonella should immediately come to mind. Pseudomonas aeruginosa has its own distinctive risk factors. This opportunistic pathogen is commonly associated with intravenous drug use, where repeated bloodstream exposure increases the risk of infection. Another classic scenario involves puncture wounds through athletic shoes. The moist environment within the shoe sole can harbor Pseudomonas, allowing the bacteria to enter deeper tissues during injury. A seemingly minor foot puncture should never be dismissed if pain persists or signs of infection develop. Anaerobic bacteria also play a significant role, particularly in contiguous osteomyelitis associated with diabetic foot infections. These infections are often polymicrobial, meaning multiple organisms work together to sustain the infection. Diabetes can impair circulation, reduce immune responses, and decrease protective sensation. Small wounds may go unnoticed until infection extends into deeper tissues and eventually reaches the bone. Anaerobes thrive in the low oxygen environment of necrotic tissue and frequently coexist with aerobic organisms. The key message is simple: match the pathogen to the patient. Think Staphylococcus aureus first because it remains the leading cause overall. Remember Salmonella in patients with sickle cell disease. Consider Pseudomonas in intravenous drug users and puncture wounds through shoes. Suspect anaerobes when dealing with diabetic foot infections and contiguous spread. Recognizing these associations helps clinicians select appropriate empiric antibiotics while awaiting definitive culture results. In osteomyelitis, understanding who is at risk often points directly toward the culprit. The right suspicion leads to the right treatment, and the right treatment preserves both bone and function. The clinical presentation of osteomyelitis can vary dramatically depending on how long the infection has been present. Some patients develop symptoms suddenly over a few days, while others live with a smoldering infection for months or even years. Understanding the difference between acute and chronic osteomyelitis is essential because the presentation, complications, and management strategies are often very different. Acute osteomyelitis typically develops over days to weeks. The symptoms are usually more obvious and inflammatory in nature. Patients often complain of localized bone pain that becomes progressively worse. The pain is deep, persistent, and may intensify with movement or weight bearing. Swelling and tenderness over the affected area are common findings. The overlying skin may appear warm or red because of the body's inflammatory response. In children, parents may notice limping, refusal to use a limb, or irritability during movement. Fever is another important feature of acute disease. Patients may experience chills, fatigue, and a general sense of feeling unwell. However, not every patient will have a high temperature, particularly older adults or those with weakened immune systems. If acute osteomyelitis is not recognized and treated promptly, the infection can evolve into chronic osteomyelitis. Chronic disease persists for months or even years and is often much more challenging to eradicate. One hallmark of chronic osteomyelitis is the formation of a sequestrum. This refers to a fragment of necrotic, dead bone that has become separated from healthy tissue. As infection and inflammation compromise blood supply, portions of bone lose their vitality and die. A sequestrum acts like a protected hiding place for bacteria. Because it lacks adequate blood flow, antibiotics and immune cells struggle to penetrate it effectively. This is one reason chronic osteomyelitis frequently recurs despite treatment. The body attempts to contain the infection by producing new bone around the dead tissue. This reactive bone formation is called involucrum. Think of it as the skeleton's attempt to wall off the infection and stabilize the affected area. Another striking feature of chronic osteomyelitis is the development of sinus tracts. These are abnormal channels that extend from the infected bone to the skin surface, allowing pus or drainage to escape. Patients may report recurrent discharge from the same area over long periods. The presence of a draining sinus tract in association with underlying bone infection is considered highly suggestive and often diagnostic of chronic osteomyelitis. The key takeaway is simple. Acute osteomyelitis presents with pain, swelling, and fever over days to weeks. Chronic osteomyelitis tells the story of a prolonged battle between bacteria and bone. Remember the three classic features: sequestrum, the dead bone, involucrum, the new reactive bone, and sinus tracts, the draining pathways to the skin. Recognizing these patterns early allows timely treatment, prevents complications, and improves the chances of preserving both bone integrity and function. Diagnosing osteomyelitis can be challenging because its symptoms often mimic other musculoskeletal conditions. A patient may simply complain of persistent bone pain, swelling, or difficulty using an affected limb. The key is knowing when to suspect infection and using the right tools to confirm the diagnosis. The diagnostic journey often begins with clinical suspicion. Persistent, localized bone pain that does not improve as expected should raise concern, especially in patients with diabetes, recent trauma, surgery, bloodstream infections, or chronic wounds. Laboratory tests can support the diagnosis. Inflammatory markers such as erythrocyte sedimentation rate and C-reactive protein are often elevated. However, these tests are not specific. They can tell us that inflammation is present, but they cannot confirm that the bone itself is infected. Imaging studies therefore play a crucial role. Plain radiographs are usually the first investigation because they are widely available and inexpensive. The challenge is that early osteomyelitis may not be visible on X-rays. Bone destruction often takes days to weeks before it becomes apparent. This is where magnetic resonance imaging, or MRI, becomes invaluable. MRI is considered the best imaging modality for early detection of osteomyelitis. It can identify bone marrow edema, soft tissue involvement, abscess formation, and the extent of infection long before significant changes appear on conventional radiographs. Despite advances in imaging, the gold standard for diagnosis remains bone biopsy with microbiological culture. Obtaining a sample directly from the affected bone allows clinicians to identify the exact pathogen responsible for the infection. This information is essential because it enables targeted antimicrobial therapy rather than relying solely on broad-spectrum treatment. Once the diagnosis is established, management requires patience and persistence. Bone infections are notoriously difficult to eradicate because antibiotics penetrate bone tissue less effectively than many other body sites. Most patients require prolonged antimicrobial therapy, often lasting several weeks. Treatment may begin with empiric antibiotics aimed at the most likely organisms and later be tailored according to culture and sensitivity results obtained from the biopsy. Monitoring the patient's clinical response is equally important. Improvement in pain, reduction in inflammatory markers, and restoration of function all suggest that therapy is working. In chronic osteomyelitis, antibiotics alone are often insufficient. Areas of necrotic bone can act as reservoirs for bacteria, shielding them from both immune defenses and antimicrobial agents. In these situations, surgery becomes essential. Surgical debridement removes infected and dead tissue, reduces bacterial burden, and creates a healthier environment for healing. In some cases, reconstruction procedures may also be necessary to restore stability and function. The key takeaway is simple. Think of osteomyelitis early. Use MRI to detect disease before extensive damage occurs. Confirm the diagnosis whenever possible with a bone biopsy, the true gold standard. Treat with prolonged antibiotics, and remember that chronic infections often require surgical debridement. Successful management is rarely quick, but with accurate diagnosis and a comprehensive approach, bone can heal and function can be preserved. Section 3 brings us to joint infections, conditions that can rapidly destroy cartilage, impair mobility, and permanently affect quality of life if not recognized early. In this section, we focus on septic arthritis involving both native joints and prosthetic joints. Septic arthritis occurs when microorganisms invade the joint space, triggering an intense inflammatory response. Although the infection itself is dangerous, much of the damage actually results from the body's attempt to fight it. Inflammatory cells release enzymes that can rapidly erode articular cartilage. In some cases, irreversible joint destruction can occur within days. Native joint septic arthritis affects joints that have not been surgically replaced. The infection often arrives through the bloodstream, although direct inoculation from trauma or extension from nearby infections can also occur. Patients usually present dramatically. A joint that was functioning normally may suddenly become painful, swollen, warm, and difficult to move. Pain is often severe. Even gentle movement can be unbearable. Patients may hold the affected joint completely still because any attempt at motion worsens the discomfort. Fever is common but not universal. Its absence should never rule out the diagnosis. Large joints are most frequently involved. The knee is the classic site, followed by the hip, shoulder, ankle, and wrist. In children, septic arthritis of the hip is particularly concerning because delayed treatment can result in long-term disability and growth disturbances. Prosthetic joint infections present a different challenge. These infections involve artificial joints placed during procedures such as hip or knee replacement surgery. Bacteria can attach to the surface of prosthetic material and form biofilms, protective communities that shield microorganisms from antibiotics and the immune system. Patients with prosthetic joint infections may develop persistent pain, swelling, stiffness, reduced joint function, or drainage from the surgical site. Some infections appear shortly after surgery, while others emerge months or even years later through bloodstream seeding from distant infections. The key message is simple. A painful, swollen joint should always be treated as an emergency until proven otherwise. Septic arthritis is not just a joint problem. It is a medical emergency that threatens both function and independence. Prompt recognition, urgent diagnostic evaluation, and timely treatment are essential. Early intervention preserves cartilage, protects mobility, and dramatically improves outcomes. In joint infections, every hour matters because the longer bacteria remain in the joint, the greater the risk of permanent damage. By recognizing the warning signs and acting quickly, clinicians can prevent lifelong disability and help patients return to pain-free movement and normal daily activities. Native joint septic arthritis is a medical emergency hiding in plain sight. A patient may walk into the clinic with what appears to be a painful swollen joint, but without prompt treatment, permanent cartilage destruction can occur within days. In this condition, every hour truly matters. Non-gonococcal septic arthritis refers to bacterial infection of a natural, non-prosthetic joint that is not caused by Neisseria gonorrhea. The infection most commonly reaches the joint through the bloodstream, although direct trauma or spread from nearby tissues can also occur. The classic presentation is acute monoarthritis, meaning the sudden involvement of a single joint. The knee is the number one site affected, making it the joint clinicians most often encounter in practice. However, the hip, shoulder, ankle, wrist, and elbow can also be involved. Patients typically describe the abrupt onset of severe pain. The discomfort is often intense and disproportionate to what might be expected from minor injuries. Even small movements can become unbearable. The affected joint usually appears swollen, warm, and tender to touch. Redness may be present, although it is not always obvious. Patients often refuse to move the joint and may hold it in a position that minimizes pain. Fever is common, but its absence should never provide reassurance. Older adults, immunocompromised individuals, and patients with chronic illnesses may present without a significant temperature elevation. The most important step in diagnosis is arthrocentesis, also known as joint aspiration. This procedure is essential and should never be delayed when septic arthritis is suspected. Synovial fluid obtained directly from the joint provides critical diagnostic information. The aspirated fluid is evaluated for appearance, white blood cell count, crystal analysis, gram stain, and culture. In septic arthritis, the fluid is often cloudy or purulent. One classic laboratory finding is a synovial white blood cell count exceeding 50,000 cells per microliter, with a predominance of neutrophils. Although lower counts do not completely exclude infection, very high counts strongly support the diagnosis. Importantly, clinicians should not assume that a swollen joint is caused by gout or another inflammatory condition without first excluding infection. Missing septic arthritis can have devastating consequences. Management requires both source control and antimicrobial therapy. Antibiotics alone are often insufficient because infected fluid within the joint continues to damage cartilage. Urgent drainage is therefore essential. This may be accomplished through repeated needle aspiration or arthroscopic washout, depending on the joint involved and the severity of infection. Removing purulent material reduces bacterial burden and relieves pressure within the joint. Intravenous antibiotics should be started promptly and later adjusted according to culture results and susceptibility testing. The key message is simple. A hot, swollen, painful joint should always be treated as septic arthritis until proven otherwise. Perform arthrocentesis early. Drain the joint urgently. Start appropriate antibiotics without delay. Rapid action preserves cartilage, protects mobility, and prevents lifelong disability. Disseminated gonococcal infection, often abbreviated as DGI, is an important cause of septic arthritis that every healthcare professional should recognize. Although many people associate gonorrhea only with localized genital infections, the bacteria can sometimes spread through the bloodstream and affect distant parts of the body, including the joints, skin, and tendons. Disseminated gonococcal infection is considered the most common cause of septic arthritis in young, sexually active adults. What makes it particularly challenging is that patients may not have obvious genital symptoms. In fact, many individuals have no urogenital complaints at all, making the diagnosis easy to miss if clinicians fail to ask the right questions and maintain a high index of suspicion. Disseminated gonococcal infection typically presents in one of two major clinical syndromes. The first is the arthritis dermatitis syndrome. This is often the more classic presentation. Patients usually develop migratory polyarthralgia, meaning pain that moves from one joint to another. The joints may be painful without significant swelling in the early stages. Tenosynovitis is another hallmark feature. This refers to inflammation of the tendon sheaths and commonly affects the wrists, fingers, ankles, or feet. Patients often complain that moving their hands or walking has suddenly become painful. Characteristic skin lesions may also appear. These are usually small pustules or papules scattered over the extremities. The lesions can be few in number and painless, so they are easily overlooked during examination. The second presentation is purulent arthritis. In this form, the infection localizes within one or occasionally a few joints, producing a picture similar to other causes of septic arthritis. Patients develop acute joint swelling, warmth, tenderness, and restricted movement. The knee is frequently involved, although other large joints can also be affected. Diagnosing disseminated gonococcal infection requires looking beyond the affected joint. Joint fluid cultures may sometimes be negative because the bacteria can be difficult to isolate from synovial fluid. This is why testing mucosal sites is essential. Samples should be obtained from the cervix, urethra, rectum, and pharynx based on the patient's sexual history and exposure risks. Nucleic acid amplification testing, commonly known as NAAT, is highly sensitive and has become a cornerstone of diagnosis. Culture remains valuable as well, particularly for antimicrobial susceptibility testing in the face of emerging resistance. The key message is simple. Think of disseminated gonococcal infection in young, sexually active adults presenting with unexplained joint symptoms. Remember the two classic patterns: the arthritis dermatitis syndrome with polyarthralgia, tenosynovitis, and skin pustules, and the purulent arthritis syndrome with an acutely inflamed joint. Most importantly, do not rely solely on joint fluid analysis. Test the mucosal sites. Recognizing disseminated gonococcal infection early allows timely treatment, prevents joint destruction, interrupts transmission, and improves outcomes for both patients and their partners. Prosthetic joint infection, or PJI, is one of the toughest complications after joint replacement surgery. And the real enemy is not just bacteria. It is something far more protected: a biofilm. A biofilm is a slimy, sticky community of bacteria. It forms directly on the prosthetic surface. Think of it like a fortified bacterial city. Once it builds up, it becomes extremely hard to destroy. Inside this biofilm, bacteria are shielded. Shielded from antibiotics, and shielded from the immune system. That is why treatment becomes so challenging. Even powerful antibiotics struggle to penetrate, and immune cells cannot easily reach the bacteria. So the infection becomes persistent, slow, hidden, and resistant. Now let's talk about how prosthetic joint infection develops over time. We classify it into timing categories. First is early infection. This happens within 3 months after surgery. It is often acquired during the operation or soon after. Patients may show acute pain, redness, or wound discharge. Next is delayed infection. This occurs between 3 to 12 months. It is more subtle. Symptoms are less dramatic. Patients may just feel increasing joint pain or stiffness. The biofilm is already starting to mature here. Then we have late infection. This occurs after 12 months. It is often from bacteria spreading through the bloodstream. A dental infection, a skin infection, or urinary infection. These bacteria seed the prosthetic surface and quietly establish a biofilm. By the time symptoms appear, the biofilm is well established, and that makes eradication much harder. This is why early recognition is critical. Because once biofilm matures, antibiotics alone are rarely enough. Treatment often requires both surgery and long-term antibiotics, sometimes even removal of the prosthesis. So the key message is simple. Prosthetic joint infection is not just an infection. It is a biofilm-driven disease. And timing matters. Early, delayed, or late. Each stage tells a different story. Understanding the timeline helps guide diagnosis and treatment, and ultimately improves patient outcomes. Managing prosthetic joint infection is all about one thing: controlling infection without losing joint function if possible. But this is never simple, because bacteria hide inside biofilms, and that changes everything. Let's start with DAIR: debridement, antibiotics, and implant retention. This is the first major strategy. It means we go in surgically. We clean out infected tissue. We wash the joint thoroughly. But we keep the prosthesis in place. Debridement, antibiotics, and implant retention works best in early infections. When the biofilm is still immature, and the implant is still stable. Timing is everything here. If you act early, you may save the joint. If you delay, success rates drop quickly. Now let's move to chronic infection. This is where things get tougher. The biofilm is fully established, and antibiotics alone cannot penetrate it. This is where the two-stage exchange becomes the gold standard. First stage, we remove the infected prosthesis. We perform aggressive debridement. We clear all infected and necrotic tissue. Then we insert an antibiotic spacer. This keeps joint space and delivers local antibiotics. Then we treat with prolonged systemic antibiotics. We wait for infection control. We monitor inflammatory markers carefully. Second stage comes later. Once infection is cleared, we remove the spacer, and we implant a new prosthesis. It is a long journey, but it has the highest success rate in chronic prosthetic joint infection. Now let's talk about a key antibiotic tool. Rifampin. Rifampin is special. It penetrates biofilms and targets staphylococcal bacteria hiding inside. But here is the important rule. Never use rifampin alone. Resistance develops quickly, so we always combine it, usually with another effective antibiotic. Think of rifampin as a biofilm disruptor. It weakens the bacterial fortress and allows other antibiotics to work better. So the big picture is clear. Early infection, debridement, antibiotics, and implant retention may save the implant. Chronic infection, two-stage exchange is the gold standard. And throughout treatment, rifampin is a powerful ally against staphylococcal biofilms. Prosthetic joint infection management is not just about killing bacteria. It is about breaking biofilms, choosing the right timing, and matching the right surgical strategy to the stage of disease. Let's wrap everything up with the big picture. These infections behave differently, so your approach must change depending on the site. Let's start with the central nervous system. In meningitis, time is everything. You do not wait. You start antibiotics immediately, and in many bacterial cases, you also add steroids early. Steroids help reduce inflammation. They protect against neurologic damage. But here is a critical safety rule. Never rush into lumbar puncture when brain abscess is suspected. Why? Because it can increase intracranial pressure, and that can be dangerous. So in suspected brain abscess, imaging comes first. CT or MRI before any lumbar puncture. Now let's move to bone infections. Osteomyelitis is often slow and stubborn. And guessing is not enough here. The gold standard is biopsy. You need tissue. You need culture. You need certainty. Because empiric treatment alone can miss the true pathogen. And when disease becomes chronic, surgery becomes essential. Dead bone does not heal. It must be removed. So debridement is often the turning point in recovery. Now let's talk about joint infections. Septic arthritis is an emergency. Every hour matters. You must aspirate the joint immediately. Before antibiotics if possible. Why? Because synovial fluid tells the story. It guides targeted therapy. And if gonococcal is suspected, you don't stop at the joint. You go searching for the source. That means testing mucosal sites. Urethra, cervix, pharynx. Because gonococcal often hides there. Silent but active. So treatment must cover both the joint and the source. Now let's connect the dots. CNS infections demand speed and caution. Meningitis needs immediate therapy. Abscesses need imaging first, not lumbar puncture. Bone infections demand proof. Biopsy is the gold standard. And chronic disease often needs surgery. Joint infections demand urgency. Aspirate first, treat fast, and trace the source. So the key message is simple. Different infections, different rules, but one principle stays the same. Early recognition saves tissue, and precise diagnosis saves lives. Thank you.